So we'll move on and talk about inflammatory lesions of the wrist and hand. So we'll talk about infections, autoimmune disease, and then talk about gout. So let's see. Jennifer, here's someone who had pain in the finger.
All right, so here we have some sagittal and axial images of the digit, and there's this increased signal intensity lesion along the distal phalanx. The glomus tumor.
Really early days, so I guess I should include that this was actually a Staph aureus cellulitis in this particular patient here, involving the pad of the distal phalanx there. Okay.
Okay.
Distal finger pain.
Yeah, so it looks like there's soft tissue swelling involving that second digit, but I'm wondering if there's also some soft tissue along the volar fat pad of that third digit as well. And there's also some signal. Yeah, so it's like underneath the extensor tendons, where if you look on the other side, they're directly opposed.
It's really
Got it. Okay.
Issue.
So it says dog bite 1 month ago. At the second digit, you can see, or is it the third? I think the second digit, you can see some increased signal within the joint space of that proximal interphalangeal joint. And you see a lot of soft tissue swelling there, and some fluid extending beyond the confines of the capsule. I'd be worried about a septic arthritis and cellulitis secondary to the dog bite.
That's what this was. Yep. All right.
Okay. We have a 60-year-old with nail dystrophy and discoloration for 1 year, and they want to rule out a glomus tumor. Okay, so here we can see kind of a heterogeneous, mostly hypoechoic central lesion with some peripheral vascular enhancement, but no intrinsic enhancement.
So just looking at this, what would you think about it?
If she had a prior trauma in this region, it could be a hematoma.
Yeah, certainly you could concern about hematoma, but that's a funny look to the nail. Just a hematoma, but this certainly could be trauma. John?
Get the mic closer, John.
Okay.
Yeah, I think it could also be a glomus tumor, although I don't see any intrinsic vascularity. Could be infection, an abscess, or fungal infection.
This is a fungal infection, and it's typical there. And the most common, certainly in our country, is candidiasis. This is in Korea, but this was also candidiasis. And you can see the appearance, typical appearance of a fungal type infection. Bacterial infections are much more aggressive than this. You tend to get pus with those, and this is as you can see, much more chronic infection. There are already a lot of nail changes, so this has been around for weeks or months. Whereas if it were a bacterial infection, you wouldn't see any nail changes because they're acute. And here we can see a lot of thickening of the nail bed.
And these are not uncommon. Probably don't see that much in MRI.
They're very common in more tropical type areas where it's wetter. They're common in the southeast United States much more than Southern California.
Okay, so 53-year-old male with increasing hand pain and swelling. So there's marked bony destructive change involving that third metacarpal head. I'm worried for and I assume it's not post-traumatic. I'm worried for some like osteomyelitis, and there's a lot of kind of soft tissue swelling surrounding that second flexor.
So you can see a lot of destructive change here.
Yeah, but you know the other one, the proximal phalanx, is actually like somewhat spared, and the margins right there actually look somewhat sharp, or sharper than you expect for like rheumatoid and osteomyelitis. So I'm wondering if there's some like non-infectious inflammatory process or either chronic infection.
This is with Staph aureus or something, you can get destruction, but you would expect to have a lot more edema. Yeah, so this is much more chronic. So this is the sort of thing you can see an atypical mycobacterial disease, or actiniomycosis, or a fungal disease. That's really the differential in something like this. And this happened to be cocci. Okay, Ashu.
All right, so I think we're looking along the radial aspect, distal radius. Looks like there's a lot of edema along those tendons. I don't know if there's even disruption there. Looks like there's Tenosynovitis, or it looks like actually synovitis along the tendon sheaths there.
I think the tendons are involved as well.
Yeah.
Okay, so what's your differential for Tenosynovitis here?
Well, I mean, diffuse Tenosynovitis, you're thinking inflammatory or infection. You're thinking, rheumatoid, psoriatic, and then for infection, often commonly seen in the wrist. And, you could see a fungal like coccidiomycosis, like the previous case. You could see other fungal infections or atypical microbacteria, like TB.
This is coccidiomycosis. Yeah, that same kind of differential. Okay.
So we have a 49-year-old male from the SoCal desert with wrist pain, and there's diffuse increased fluid within, looks like all of the tendon sheaths, especially that sixth and second, and then there's edema and osseous destruction of the carpals, particularly at the CMC joint within the trapezium, as well as
This is also
synovial thickening. Thinking this may be a chronic coccidiomycosis infection with osseous destruction and chronic tenosynovitis.
Okay, so there's significant swelling and edema surrounding that. I think this is the second digit PAP joint. The bone, I can't tell if that's actually signal within the distal aspect of the phalanx, or if that's just volume averaging.
I think the bone's okay.
Okay. So yeah, kind of diffuse synovial thickening surrounding that joint.
That patient was a diver.
Was a diver. So can it be some sort of a like some sort of infection? But I've never heard of that. So you get pricked by a Synovitis, is this just synovitis? Is it infective, or is it like just an inflammatory?
I think it's predominantly an irritant reaction.
These are not that uncommon. The main problem with these are they're extremely painful.
Yeah.
Once you pull out the barb, the pain goes away, and usually they get well. Antibiotics are used periodically, I suppose, but not necessarily as you think it's infected, but they cause swelling and they're extremely painful.
You can also see this with spider bites and other venomous type things. And you don't always have a good history of actually having a bite and so forth. They just kind of show up, and the patients may well not know. Now, if it's a sea urchin, they probably do know. But spider bites. The patients may not be aware of actually having been bitten.
Sea urchins and spiders are not close together, John.
Right. An amphibious spider. Okay.
There you go. A crab.
Right, a crab. There you go. Ashu?
17-year-old male with right wrist pain for 3 weeks. There is a focal lucency and increased sclerotic borders on the distal ulna. And there might be actually a tract extending to the articular surface. And there's some soft tissue swelling also along the ulna. So we have the MRI here. We can see that the lesion does extend intra-articularly. There's a lot of soft tissue edema or slash fluid actually. And I'd be worried about Brody's abscess.
It looks to me like it's osteomyelitis and extending through the physis.
There also could be like a subperiosteal infection too. I don't know if the yeah right there.
It's, I don't know, 17 months, or is it 17? Well, it's 17 month
17-year-old
old
male.
baby. So that they're very likely to get this through the physis because of the circulatory. They usually, a baby of this age, prior to the age of 9.
Yeah, it's a 17-year-old. John, it's a 17-year-old male.
17, it doesn't look like a 17-year-old male. I mean, I believe you, but for some reason I think that this.
It doesn't look like it's 17 years old. But.
Yeah, it just, anyway, since we're on the subject, prior to age of 9, their physis has circulation going through it from the metaphysis to the physis, a few vessels. Yeah. And ergo, prior to the age of 2, I think I misspoke before, prior to the age of 2. They're notorious to get osteo going through the physis. And they're the most common individuals to get this kind of a problem prior to the age of 2 rather than an adult.
Okay.
I think you probably know more about that than I do. That's what I haven't treated that many infections in my life, but Campbell's talks about it quite a bit.
Thanks, John.
So here we have some axial, sagittal, and coronal images of the wrist, and there's this heterogeneously enhancing fluid collection in the distal ulna with fluid extending into the adjacent soft tissues. I think this looks like an abscess and osteomyelitis.
Okay, so this is one of John's listed. This is a 1 year, 2-month-old male, so this is under 2 years.
Okay, so we see kind of significant edema, and it probably looks like some medullary expansion involving that distal radius, predominantly in the metaphysis, although it extends through the epiphysis, or through the physeal plate into the epiphysis. There's some surrounding soft tissue edema. Some looks like some cortical breakthrough, so you're concerned for osteomyelitis abscess.
Yeah. So this is your example, John, where it's actually and under 2, and it's the infections extending into through the growth plate into the epiphysis, and then we can also see all this infection in the surrounding soft tissues.
Yeah, and there's like I said, there is circulation going from metaphysis to the epiphysis, whereas it closes off after the age of 2. and then you don't see it that often. You have to go outside the metaphysis through the periosteum to get to the physis.
Yeah.
That's the difference between a 2-year-old and somebody older.
And on the gadolinium enhanced images, on the sagittals, it looks like there's cortical breakthrough. I don't know if there's like a thin rim of periosteum intact over, like holding it, if it's subperiosteal abscess, or if there's actually abscess extending beyond the cortex.
Probably some extending beyond, but a lot of this is subperiosteum. This is all subperiosteum.
What's interesting is the fact that it's that far advanced. We're talking about this probably is not in America, is it?
No, it's in South America.
South America, maybe.
Okay, so now this said a year later. How long?
10 months.
10 months later. Okay, so there's actually been a pretty like marked improvement, and we do still see a defect within the distal radial metaphysis, but I mean it looks. There's a little bit of enhancement there, and maybe a little bit of fluid signal, but I don't know if that's any residual. You know, it's probably just all kind of healing granulation tissue, I would suspect.
Actually,
All right, so we have the sagittals and coronal image. We can see diffusely abnormal signal of the intermediate and distal phalanx of this digit. I'm guessing it might be the second digit. It involves the, yeah, you can get replacement of the marrow signal and increased T2 signal. And there's also some soft tissue swelling, and the joint space doesn't look normal. So, okay, so this is treated resistant Staph aureus. Okay.
This methicillin-resistant Staph aureus treated, but so this was a really kind of a treated or in treatment osteomyelitis.
Yeah, the cortical margination actually doesn't look too bad, despite the marrow signal abnormality.
I wonder if it's still active.
I think it's still under treatment. So I guess you'd have to say that it was probably still active because they were still in the process. They were deciding when to terminate antibiotics when they got the MR scan.
All right, so we have an 84-year-old female with hand pain. I think this may be the first digit, or I can't tell, but there is diminished T1 signal intensity surrounding the DIP joint, and there's corresponding marrow edema and surrounding soft tissue thickening and edema. This looks like osteomyelitis to me. Yes.
Not a good way to treat infection using cortisone. In fact, they propagate the disease quite rapidly by eliminating your body mechanisms to fight infection.
Yeah, I think it actually got clinically worse. That's when they got the MR scan, John.
Okay, so syndrome, male left arm swelling and pain, hypertension, diabetes. So are the first top two images, it says T1 weighted, and then E and H, is that for enhanced? Enhancement, okay. So it looks, maybe like on an enhancement, it looks like there's kind of, not sure if that's abnormal muscular enhancement throughout the.
Here you can see the edema.
Yeah, there's.
That's not enhancing.
So that's what I was wondering about, because it's like the dorsal osteoarthritis is very thickened, but it's not enhancement. But are the muscles kind of had a heterogeneous appearance to me. And then on the T2, the non-enhancing is just all fluid throughout the throughout the dorsum of the hand, involving the extensor compartments as well. Okay, so there's just an extensive amount of rim enhancing fluid collections throughout the forearm. You know, throughout all the kind of the muscle fascial planes.
So certainly when you see this kind of enhancement pattern, enhancement centrally, you're either talking about large abscesses or you're talking about tissue necrosis.
Yeah.
So compartment syndrome has to really come at the top of your list.
All the muscular abnormality. I was wondering if this was all just, like I was thinking, compartment syndrome versus a,
So this is what the pathology shows, and this turned out to be necrotizing fasciitis, which probably a combination of infection and increased pressure with decreased perfusion, kind of going along with compartment syndrome together.
I don't see very good results with that situation.
Just a heterogeneous fluid signal intensity collection along the flexor, diffusely throughout the flexor tendon compartments. This is concerning for Tenosynovitis, and it could be an abscess in that flexor tendon compartment. It looks like there may be some peripheral rim enhancement. Multiple low signal intensity regions as well. Not sure. They kind of look like rice bodies, but I've never seen that in the hand before.
So what's your difference with that?
Chronic infectious or inflammatory Tenosynovitis,
So what
or this looks chronic, so atypical mycobacterial infection or coccidiomycosis.
You can also put rheumatoid arthritis in the differential, though at this stage your disease is usually pretty symmetric, and this happened to be just unilateral disease, which would make rheumatoid arthritis much less likely, and this was atypical mycobacterial disease.
Okay, so there's a large amount of increased fluid signal throughout the flexor tendon sheaths. And it looks like it's propagating along that second digit flexor tendon. I'm not sure it's fluid. I don't know if this is fluid or if it's just like marked synovial thickening. And so, I mean, I'm concerned for like a rip-roaring Tenosynovitis.
And you can see that there is stretching of the flexor.
Yeah, it's incredibly bowed.
This is chronic Tenosynovitis.
Yeah.
That's what this is. And you can think about, it goes along one digit, so you might think about something like a psoriatic arthritis, where you get dactylitis.
Like the sausage digit.
You never really see this kind of significant enlargement of the flexor area with psoriatic arthritis. This was atypical, but it's a chronic infection. This could also be seen in something like TB. And that would certainly in our area include cocci in the differential on something like this. Ashu.
I wonder how far that goes in the finger.
I think on that one it went all the way to the distal end of the finger.
And the tendon is away from the bone, and that's not very good.
Yeah, right.
So we're looking at I think the flexor tendon sheaths.
Okay.
Here you could see a lot of edema, and there's a bunch of small, what appears to be low signal intensity bodies within the tendon sheath. You can see it both on the axials, on the radial and bursal side, within the flexor tendon sheaths. It probably extends to the carpal tunnel. I'd be worried about infection here. The tendons themselves look pretty well preserved. There may be some mild tendinosis. So again, microbacterial avian tenosynovitis.
Here there is diffuse marrow edema throughout the carpals, distal radius, and there are erosive changes in the lunate as well as the distal ulna to a lesser extent, and the capitate, distal scaphoid, and there's a DRUJ joint effusion. This may be a chronic inflammatory process such as rheumatoid arthritis. Yeah.
I don't think John's going to throw rheumatoid at us today.
Yeah, we might start getting
I
into it later in the
think.
conference, but I think what I'm going to show right now are going to be all infectious things, so you guys can cheat.
So, 7-year-old female, mass with slight pain around right wrist, about 2 years, no fever. Physical examination, mass are soft. Lab findings, no specific positive finding. Okay. So what I'm seeing initially is some degenerative change kind of at that CMC joint first thing, then there's mild degenerative change radiocarpal joint. And then now we're seeing this kind of large soft tissue infiltration within the, yeah, there's some, there's lucencies. Okay, so down on the bones there's, abnormal marrow signal within the, pretty much throughout the entirety of the carpals, and then involving the phalanges right there, and then there's large soft tissue infiltration kind of, expanding in between.
Well, it's more of the forearm going to the hand.
Yes. So this, on the fluid sensitive sequences, it looks like it's either a large fluid collection or maybe it's just like massive synovial thickening. Like you said, worried about some kind of atypical chronic infection. And now we can see that this fluid collection is rim enhancing, and there's just diffuse synovial thickening and abnormal signal throughout all the carpal marrow and some of the phalanges.
It looks like a lot of pus, doesn't it?
Yeah.
So, this kind of pus,
but
so if the patient stand for strep, the patient would be toxic.
And it said labs were normal and no fever.
What disease would you think about? They could give you huge cold abscesses without the patient being very sick. It's pretty classic for TB. Yep. Ashu.
All right, here we see scattered lytic lesions throughout the bones, carpals, distal ulnar radius, humerus, at the greater tuberosity, some of the carpal bones as well. I don't know if there's a scaphoid waist fracture there or if that's just how irregular it looks. That might be a pathologic fracture as well. I'd be worried about, so this is a 50-year-old with illegal arthropathy. Okay, so multiple. Oh, and you can see here that there's, again, that kind of complex tenosynovitis with multiple low intensity bodies. I mean, I still worry about a diffuse tuberculosis infection. You can see it in, oh wow, it's also involving the the humerus, the proximal humerus. You can almost see like an abscess there, intraosseous abscess, and they're all rim enhancing fluid collections extending both intra-articularly and then within the osseous cavity. There might even be a, I think there probably is a pathologic break in the cortex there along anterior margin. So yeah, it all looks like TB.
Have you guys seen TB like this before?
Not here.
Yes.
A 37-year-old with ulnar-sided wrist pain. There is a lucent lesion in the distal ulna. I don't see any other lesions, but it is hypointense on the T1 images, and there's surrounding edema and soft tissue. edema. If he doesn't have a history of trauma in this region, this could be infectious. I guess it could be TB or atypical infections. Mycotic granuloma.
This turned out to be a fungal infection. I don't know which fungus it was. But again, it's kind of more of a chronic destructive type lesion. But certainly, in the right TB would be differential.
I'm sorry, on X-ray, it didn't show much sclerosis around the lesion, so it looks kind of a aggressive type of.
Yeah, but though the zone of transition is very sharp here, so it's you know it's certainly a well circumscribed lesion, but there is no bony reactive change at this point. Right.
And that's what makes you think that this aggressive sucker.
Yeah. Well, it's an infection. You can see edema around it. So let's go ahead and talk a little bit about rheumatoid. You guys have seen this picture before, so we really don't want to see that again. We went through the different phases of rheumatoid before, right? We don't need to. Did we or not? We did. Oh, we didn't? Oh, okay. Then let's. Well, let's. Okay, so let's talk about the pathogenesis of bone destruction in RA, and this. I don't know that you'd find this discussion anywhere in the literature, but typically it starts out typically as a synovial inflammatory disease, a true inflammatory disease, mediated by the complement cascade and other biochemical and cellular inflammatory changes. Then what happens is for the bone disease, you get infiltration into the bone and at the capsular insertions. Now, I think we'll talk about this in detail, but basically, either the synovial inflammatory cells extend through the cortical bone at the capsular insertion due to microfractures and migrate into the marrow space, or what happens is that the synovium, or maybe both, produces biochemical changes that diffuse through microfractures in the capsular insertion of the cortex, which then draws in inflammatory cells from the marrow space, producing osteitis at that location. And I'll show examples of this in a minute. Then what happens is the fat in the marrow around where the capsule inserts gets replaced by inflammatory cells. Fat cells primarily have fat in them. Inflammatory cells primarily have water in them. So you get a change in the MR appearance from something that looks like fat to something that looks like edema. So it's typically called bone marrow edema lesions, but in reality, the water is primarily within the inflammatory cells that replace the fat. So it's not really true extracellular edema in the traditional standpoint, but that's kind of what it looks like on MR. So in the rheumatology literature, these are called BME lesions or bone marrow edema lesions, but what it probably is primarily an osteitis. That's what it shows histologically. Now, the inflammatory cells, however, produce a lot of chemicals that dissolve the trabecular bone and destroy the trabecular bone. Now, if you destroy trabecular bone, that has a three-dimensional structure. And it's just like if you destroy a building that has all kinds of internal struts and so forth, unless you have blueprints, you can't repair it properly. Now, if you break the cortex of the bone, the periosteum grows over that fracture, which acts as a scaffold and a blueprint to allow the osteoblast to come and create new bone. But if you have a trabecular bone out in 3D space, there is no periosteum to grow over it. So once you destroy the trabecular bone, it's destroyed. And what happens is, because of the stresses, you get increased thickening of the trabecular bone around it. and you end up creating what we call a geode. We have a central hole and an area of sclerosis around it. And that's the way the trabecular bone heals itself, because it does not have stored in its memory banks what the 3D structure of the struts and plates are like in the trabecular bone. And therefore, once you destroy trabecular bone, that's an irreversible change. And then once you destroy the trabecular bone, what will happen is that you'll continue to dissolve bone, and it'll go to the cortical bone or the subchondral bone, and then you'll get a typical erosion. Now, in the inflammatory stages, up until where you have really irreversible marked destruction of the trabecular bone, you will not see changes by any X-ray techniques, because you don't have enough change in the X-ray density, either by CT or plain films. Once you destroy a significant amount of trabecular bone, it's irreversible, and then you can start seeing changes on a CT examination. And then much later, primarily when you start getting the hypertrophy of the bone around the area of destruction because of the stresses that are displaced, you'll start seeing changes on a plain film. So early on, you only see these lesions by MR. So we get destruction of trabecular bone, that goes on, that destroys the cortex, where you now have a traditional erosion. But notice, we're 5 steps into this pathophysiologic mechanism before you actually have a lesion that can reliably be detected by X-rays. So X-rays are a late finding, and unfortunately, when you get X-ray positive, it's irreversible in large part. Now, once, and I'll show examples of this in a minute, once you destroy the bone, especially the subchondral bone, it will grow, the inflammatory disease will destroy the subchondral bone. There's now no longer a substrate for the cartilage, so that causes the cartilage to disintegrate, and then you get articular cartilage and joint destruction. So these are the phases, but only the last phases could be seen by the traditional techniques we used in the past. So now you can see synovial inflammation by ultrasound outside the bone, but not inside the bone. And then we can see. So there are technical issues when you do MR scan. Really, to evaluate for erosive changes in the bone, you really would like a voxel size where the maximum diameter of any side is 1 millimeter. Which, as we've talked about before, at low field, you can do that with 3D gradient echo images, but because of the susceptibility artifacts you get at 1.5 and 3, you can't really use those techniques. At 3T, we can get close to this by using PD-FATSAT and other fast spin echo type techniques. At 1.5, we're kind of in a no man's land. Contrast has been shown to be erosions, the erosions, and also the synovitis, the osteitis, will enhance with contrast. So contrast does increase the sensitivity somewhat. And again, it depends a little bit upon field strength. And contrast significantly increases the sensitivity for synovitis, especially Tenosynovitis. So in areas like Europe, where they use a lot of MR scan in clinical practice, they've developed shortened sequences of 3 sequences where they'll do a kind of a T1 PD-FATSAT and then a T1 post technique to try to have cost-effective imaging. We did most of our studies in rheumatoid arthritis at low fields in office scanners, where we didn't really want to give contrast. And so for the inflammatory lesions of the bone, we had very good sensitivity and specificity using STIR and gradient echo type imaging. I think non-contrast MR is less sensitive for early synovitis, but as we'll talk about a little bit later, the reason why we're using MR was really to look for bone lesions as an indication for moving on to TNF-alpha inhibitors, in which case we didn't feel that contrast was all that important. But if you're using MR to detect early synovitis to make the diagnosis of rheumatoid arthritis, then contrast enhancement does increase your sensitivity early on. This is these are 1.5T imaging. We can see a little bit of cortical irregularities of the margins here. This is normal indentation. That's normal. This is normal. That's a little bit irregular on a T1. You can do 3D gradient echoes, but you lose a lot of contrast with these. This actually was a little bit of an erosion, but these are non-specific, and I wouldn't call this positive just on an MR examination. Now here we can see here a little more focal erosion. This was actually in the same patient, both on the T1 and the gradient echo type image right in that location, and you can follow it through. And then you can see that because of the thicker cuts with PD fat set, the lesion is somewhat less conspicuous. And so these are the images that a lot of people use at 1.5T, and for smaller lesions, you get too much partial volume artifact. Now, studies have shown that these kind of erosions at the margins, at the insertion of the capsule, especially on the radial side, are seen commonly in people who do not have rheumatoid arthritis. And you can have chronic traction injuries in this location. And typically the cutoff is kind of 3. 3 or less can commonly be seen in people without inflammatory disease. More than 3, or lesions that aren't in typical high-risk lesions are more likely to be inflammatory disease and not just repetitive trauma. Here we can see many more than 3 lesions, and this was a patient with rheumatoid arthritis. And this is also another patient with multiple lesions here with rheumatoid arthritis and synovial thickening.
Sometimes it can be difficult to tell if it's like small erosion versus like subchondral cysts, in the carpals.
Well, I don't know what you mean by subchondral cysts and small erosions. It depends upon how you make the definition. Now, the definition now, if you use X-ray techniques, an erosion requires loss of the surface of the bone and a defect going into the bone. With MR, often you'll just see these bone marrow edema lesions, which we like to call osteitis lesions, where the overlying bone looks to be intact. Here, it's not intact. Post-traumatic cysts can really look very similarly, and even if you have chronic repetitive trauma from strain at the capsular insertions, you can get subchondral cysts or geodes, but they may not be filled with fluid. They may be filled with synovial tissue. So since we can't really differentiate that very well, if they're the typical small lesions, if they're big lesions, it's a different story, but that's not what we're concerned about. Smaller lesions like this, if they're marginal, I like to just call erosive disease.
At this stage, you already have synovium in the joint.
Yeah, a lot of synovial thickening here. Yeah, this is typical rheumatoid.
Erosive change.
Yeah, and here we can see a lot of synovial thickening around here, as well as the erosive changes. And this is just pretty classic rheumatoid arthritis.
When you do surgery, you don't even see the bone, cortical bone. It's usually just mush.
Okay.
And best I can describe it.
Okay. So the findings that we can see in rheumatoid arthritis with MR, we can see soft tissue changes, which are nonspecific, where you get thickening, especially synovial thickening around tendons and in joint spaces. You can see edema within the soft tissues, and you can get enhancement. But you can see these in trauma. You can also see these in infections, especially the more chronic infections. Bony changes are more specific in our experience. Erosions, especially if you have 3 or more, tend to be less subjective than soft tissue thickening, and higher association with having rheumatoid arthritis. And then you can also see edema patterns in bones, and inflammatory edema pattern is very different than trauma. So it's pretty easy to differentiate those, except for the chronic traction changes that you see at capsular insertions. And if you have one or two, you really can't differentiate the two. But if you have more than that, especially with synovial thickening that's more diffuse, then you're much more likely dealing with inflammatory disease. And then you can see joint space narrowing. That's just an indication that you've lost articular cartilage. And as you know, that's nonspecific. Joint destruction you can see in degenerative disease, osteoarthrosis, etc. And then also deformities can be post-traumatic as well. So let's talk about the details of the cortical destruction or the erosions that you see with rheumatoid arthritis. Now, when I was in medical school, and I don't know what you guys learned in medical school, but at least back in 2007, there was a paper in Arthritis and Rheumatism from McGonigal et al., who's a pathologist in England, where they talked about the erosions with rheumatoid arthritis being in the bare area. And that's the area between where the articular cartilage stops and the capsule inserts. And that's what I was always taught. And that's what they said in this particular paper. But in this same group, and then this is classically what we call erosion, is when you destroy the cortex in this location. If you have for bone destruction, MR and CT are very similar, but MR is much more sensitive than radiographs. And even back when I made this slide, there were over 50 peer-reviewed studies to show that MR was more sensitive than X-ray techniques. But McGonigal went back and looked much more carefully when they were trying to figure out, and the concept at that time was the erosions occurred here because you could have the synovitis directly adjacent to the bone, and the bone wasn't protected by the articular cartilage and wasn't protected by the capsule insertion here. That was the theory back in those days. But McGonigal back, they went and did another paper where they looked much more carefully at the detailed anatomy in this area in patients with rheumatoid arthritis, and it turned out that old theory that was dominant for 100 years probably is not correct. They found out with much more detailed studies in this 2009 paper that the erosions tend to occur right at the capsular insertion, not in the adjacent bare area. And that's when people started thinking about, well, a lot of the erosive changes in rheumatoid arthritis may be associated with traction trauma to the bone in this location. And then the two concepts that I talked about earlier kind of came in vogue. And you can see these erosions by ultrasound sometimes. If the overlying bone is destroyed, you can see the destruction there and the inflammatory disease and the cellular component going into it. And then, so looking at more MRs, this is a non-specific finding. We have synovial thickening. Most commonly, we'll see this in trauma to an individual joint, but this could also be infection. It could also be inflammatory disease. Typically, though, it's not going to be rheumatoid or psoriatic type arthritis or inflammatory bowel disease unless more than one joint's involved. And obviously, it could be neoplasm, though then you'd have to see other neoplastic features than this. So here is here's a patient that had very early pain in the wrist. And what we can see here is what really looks like a normal distal radial ulnar joint space with a little bit of a loss of fat saturation here. But with giving contrast, what we can see is enhancement of this particular synovial tissue where the other synovial tissue in the wrist did not enhance. And this is where the patient was painful, and this patient turned out eventually to have rheumatoid arthritis. And this was very early synovitis and rheumatoid arthritis without evidence of osteitis or bone disease. Back in around 2000, we were very interested in looking at dynamic contrast enhancement to try to differentiate the etiology of the disease process that was producing the synovial thickening. This is a study of ours, but there was a paper in Arthritis and Rheumatism where they talked about early enhancement in dynamic MR enhancement studies was much more specific for rheumatoid arthritis and infectious arthritis than it was in osteoarthrosis or other chronic changes like that. So here was a study on a 1 Tesla scanner. This was 12 seconds after a bolus injection. What we can see is thickening of the synovium around the second and third metacarpophalangeal joints, but we're not really seeing much enhancement at this time. If we wait to 24 seconds, we can see early enhancement right in through here. And if we go all the way out to 36 seconds, we can see marked enhancement. So this is a positive perfusion study, which is much more specific for rheumatoid arthritis, if you've excluded infectious etiologies. Basically, degenerative changes in chronic disease will not enhance in the first minute after contrast enhancement, whereas acute inflammatory disease will. So why this study's here, forget this. I don't know. Anyway, this basically shows that you can also get involvement with the inflammatory disease of the ligament structures and the tendinous structures around the joint. And this happened to be a sagittal band tear, someone with rheumatoid arthritis. The concept, you can get a lot of tears of different structures in the hand with chronic synovitis from rheumatoid arthritis because it starts destroying the collagen integrity, the ligaments and the tendons. This happens to be a sagittal band tear, but that's one of the reasons why Boutonniere deformity and other deformities of the hand are kind of in the past were thought to be very characteristic of rheumatoid arthritis because rheumatoid would destroy a lot of these elements. And hopefully we won't see that anymore now that we've got treatment for this disease.
Surgically, in the past, in the 70s and 80s, when I and Dr. Marmory used to do a lot of these, we do maybe 10 cases a day. We used to remove a lot of synovial tissue. We did synovectomies routinely. And what was interesting is we would reconstruct a hand and eliminate the Boutonniere deformities. And they looked pretty good after we got done with the hand from the ulnar drift, etc. But the thing is, the function was no better. In any case that we used to do, they looked much better. The women loved it, but their function was the same as before. So unfortunately, surgery did not improve function.
Yeah. So this is an example here. This is the typical Boutonniere deformity, where you have kind of a fixed flexion of the proximal interphalangeal joint, extension of the distal interphalangeal joint, and you could put the proximal interphalangeal joint in through the opening in your jacket, which was where you put the boutonniere for the flowers, and therefore this is the Boutonniere deformity. And what occurs here is you get, in this case, destruction really of kind of the sagittal band and the stabilizing structures of the extensor tendons. They dislocate over to the side of the joint, so they now pull from this direction rather than from over the top, and that produces, when you try to when you contract these extensor muscles and the tendons, that pulls down on the sides of the middle phalanx, producing the Boutonniere deformity. And so it flexes the proximal and extends the distal. And because the tendons are pulling in the wrong direction, the patient can't control that and have a normal motion of the hand. So that's a sagittal band tear, which for chronic rheumatoid arthritis is one of the common findings. The other thing you could have is just destroy the capsule, and you can get very characteristically with rheumatoid arthritis, you get a lot of instability patterns within the hands and wrists. And we're going to talk about some of these because some of them are pretty specific for rheumatoid arthritis, which can be helpful in making the diagnosis. Here's just a lot of capsular laxity. You can see destruction of the joint space and and subluxation and instability. Another common finding that you can see in rheumatoid arthritis, probably the earliest and most common and most specific, is volar subluxation of the proximal phalange bases with respect to the metacarpal heads. They can, and we'll see other examples of that, and we see it all the time in the rheumatoids that we look at right now. In times, what will happen with all this capsular laxity and the pull from the tendons is you'll get volar, sometimes lateral, and proximal displacement of the proximal phalanges. As you see here, this is chronic. We've already had remodeling of the cortex of the proximal phalanx by the metacarpal head, and you then tend to get ulnar deviation of the hand, a classic finding in rheumatoid arthritis. And that's again because the tendons have subluxed off because of the sagittal band destruction, and now the tendons are pulling from the wrong direction, and they're pulling the fingers off to one side rather than staying properly aligned. And this is what in extreme examples it looks like. You have proximal displacement of the base of the proximal phalanx with remodeling of the distal part of the metacarpal bone here. We typically see much more subtle examples, but if you have a case and you're concerned about what the diagnosis is, and you see some subtle volar and proximal displacement of the proximal phalanx with respect to the metacarpal head, that's a very characteristic finding that's seen in rheumatoid arthritis and not really in psoriatic arthritis or other arthritides.
We used to use, John, silicone prosthetics.
I'll show some of those.
Swanson invented them, and they would last maybe 6 months to 12 months, and then it would disintegrate. The only improvement that we got was the positioning of the joint. The joint stayed in a better position, but the function wasn't any better. Now they use metallic joints, and they seem to be better, but the function still is not very good. You may get, instead of having 10 degrees of flexion and extension, you might get 20 to 30, but they look better. And I know especially one individual that plays golf with prosthesis in his MP joints, and he plays pretty well.
Good.
Without pain, so it's kind of interesting.
Well, maybe I should have that surgery before I play golf again.
I didn't know you had a problem, John.
But the problem is that I can't play golf.
Well, that's universal.
Which you know perfectly well since we played golf together.
95% of people don't know how to play golf, and the other 5% struggle.
Okay, and here's an example where we see the marked instability of the wrist due to this process with dislocation and proximal migration of the carpus with respect to the distal radius and ulna in a patient. And here we can see the two bones overlapping one another, which they shouldn't. So that's a radiocarpal dislocation and chronic rheumatoid arthritis. Michael, what do you think of this?
So there's just a marked amount of fluid within these tendon sheaths, the flexor tendons, very compatible with diffuse synovitis, which you can see with rheumatoid arthritis.
Tenosynovitis from rheumatoid disease. What do you think's going on here? Ashley, what do you think of this case?
You can see some joint space irregularity, some sclerosis along the distal aspect of the radius. You see some cystic or lucencies like the distal aspect of the ulna, and also in the scaphoid and looks like there's some cystic erosions also at the proximals, third and fourth metacarpals, and so this all is concerning for cystic erosions and rheumatoid.
You also see a lot of osteoporosis.
Yeah.
Let's see. Okay, here's the MR.
So the MR, obviously a lot more sensitive. You can see synovitis diffusely. You can see the erosions kind of involving all the carpals, as well as throughout the proximal aspects of the metacarpals. And there's osteitis of the trapezoid, and there's also probably tenosynovitis, and there's diffuse synovial thickening along the dorsum of the wrist.
Rip-roaring, long-standing rheumatoid arthritis. Okay, last case.
Okay, so here we have axial and sagittal images of the hand, and again, it looks like there are some erosive changes along the distal ulna, and there's a large amount of fluid in the ECU tendon sheath, synovial thickening, and also an erosion there in the, I can't tell for the distal radius or. Okay. This is all rheumatoid arthritis.
Synovial disease and rheumatoid arthritis. Okay, why don't we stop here today? Any questions?
I'll make a comment. Doing tenosynovitis synovectomies give you better results than joint synovectomies. Probably because you eliminate circulation in area, and you don't get as much recurrence.
Good, thanks.
So get rid of all the mushy swelling, which especially females don't appreciate.
How extensive are this?
And pain. Pardon me?
How extensive are tendinous synovial resections?
I didn't catch that.
Yeah.
John, how extensive is a synovectomy if you operate on these?
Can you say that again, John?
Like, I'm just wondering, like, how extensive the surgery is doing a synectomy for along the tendons.
Do they do that today?
No, he was asking, when you did this, how extensive did you dissect the?
Very extensive. You try to get every little morsel.
Okay.
So we took our time. We didn't rush it, but we were very careful not to damage the pulleys. The pulleys are very, very important, as you have learned, and you have to be very, very careful with the pulleys. But otherwise, we were very, very careful and very, very meticulous. Unfortunately, in a joint that just you couldn't get every cell, and that's the problem.
All right, thanks everybody. We'll do it again tomorrow.
No, we won't. We'll do it on. Well, wait a minute. Today's Monday, isn't it?